Hello and welcome back to another video with the Practice Nurse Mentor. I'm Alicia and I appreciate you joining me once again. So this time I thought that I would um, do a video on just going through the MBS item descriptor for the new chronic condition management plan. It's been about a week now since the new changes came in. There's still some greyness and a bit of confusion around the changes, the new framework, the transitioning from old methods to the new methods, especially with things like referrals and documentation and stuff like that. So a lot of the information really is set out in black and white in the descriptor. Yes, I know that MBS can be a little bit open to interpretation at times. Not going to say that it's perfect this time around, but there is there is a lot of clarity involved if you are willing to look through it. There's a lot of notes to read. There's explanatory notes attached to the MBS descriptor for the 965 and the 967. You really need to just kind of tease through them and just read through bits and pieces to make sure that you're clear on it. So I'm hoping that I can help with that a bit with this video. I'm literally just going to be going through the MDS descriptor. So if you want to get that up on your screen, or you can just follow, along on this screen here. But the reason I decided to do it this way is so that you could then go and see where it is in the descriptor. It's in black and white. If you need to show this to your practice manager, if you need to show this to your GPs or your colleagues, even some of the allied health providers are very confused about all the changes. I don't think that they've kept themselves up to date with everything. So then you know exactly where to find it and you can refer back to it time and time and again and you'll know where it is. Okay. Alrighty. So as you can see here, we've got the new 965 is the item number for performing a chronic condition management plan. So this is for patients that have got one or more chronic condition and they are likely to benefit from a structured approach to managing their chronic condition or multiple conditions. So this structured approach is really important because we do still need to make sure that we are meeting the requirements that are set out below. And the whole point of this is that it's a future-focused plan. It's not something that it's a one and done, you do it once a year, claim your money, and you may or may not do any or many reviews throughout the year. Part of the overhaul of this structure, this framework, I should say, is specifically because they want to encourage more reviews. They want this to be a living document that is constantly being reviewed and updated and edited, and it's in line with meeting the patient's goals and obviously the medical aims and treatment goals as well. But this is a collaborative effort with the patient that we're looking at how we are going to manage their chronic condition moving forward, okay? So in that respect, we then see throughout the next little part the essential elements of creating a plan. Not too much has changed here. Yes, we need to outline what that chronic condition or conditions are and the associated health needs there. Are we going to look at any health and lifestyle goals that the patient and or doctor would like to ensure are included in the plan? What actions we're going to take, what treatment and services, and are we going to include any kind of multidisciplinary care in amongst all of that as well? If we are going to refer to these other multidisciplinary team members, then we're going to get consent for that, especially if we're going to be sharing relevant information, parts of the plan or the entire plan with those people. And of course, the usual record keeping requirements still remain intact. 967 for GPs is the number that we do for reviews. Now, this is also something that I think I need to highlight moving forward because, oops, what have I done? Get out of there. Because we need to discuss and document the patient's progress in relation to the goals mentioned in their plan. So it can't just be, hey, how you going? You're here for a script today. Oh, whilst you're here, I might as well just say I've done a review on your care plan and bill a 967. Unless you're going to document that you've gone through these steps and that's not going to meet the Medicare requirements and you leave yourself vulnerable to an audit. So we need to look at the progress of the patient in relation to their goals, whether it's your goals or the patient's goals. What updates do we need to make to the plan, whether the goals have been met or to what degree they have perhaps been met? Have we got any information that's been given to us by those multidisciplinary team members? Have we got a specialist letter from a consult that they've had? Have we got physiotherapist input after they've attended their appointment or something? If there's any of that information that has come back to you, then you need to ask about this with the patient and get the feedback from the patient as well, how they think that it's going. And is this something that they want to continue to do? Do we need to change it? And therefore we update that plan as a result of those discussions. Okay. So it's not just a simple, I'm going to bring them in, I'm going to do their obs, and hey, how you going since the last time I saw you? How's that podiatry working out for you? Not quite enough. Okay, so you need to really make sure that this is thoroughly documented, that you followed up on some of these items from the plan, and then we can call it a review. Okay, this has the capacity to work really well in terms of lining it up with future appointments for the patient, so that if you're a practice that bulk bills your care planning, then they can come in and have a structured appointment with you and the GP, and this is bulk billed for them. You can be doing this once every 90 days. Okay, so this is an opportunity for them as part of their plan, as part of their chronic condition management, that they once every 3 to 6 months, they come on in and have a structured review with you. And in that time, you can review their medications, you can review the treatment protocols or plans, follow up on any investigations, and that can be all included in that review. So I think this really does have that capacity to work well for the patient and their ongoing care. And I think that's what Medicare really want from this. Okay. There's a bit of information there about who's considered a multidisciplinary team member. I'm not going to go through that. When should we consider doing a plan? So this is for anyone that's got at least one medical condition and that has been or is likely to be present for at least 6 months, or this is a terminal condition. There is no specific list of what that means in terms of it must be in this group A or group B of conditions before it will qualify. It is up to the GP to use their judgment to determine whether an individual patient will benefit from a structured chronic condition management plan. So it does discuss a little bit further here, do they need to be diagnosed with a specific disease or a pathological condition? No, they do not. The patient just needs to be experiencing this chronic condition, and they've given the example here of pain, chronic pain. Maybe we're still trying to determine what the etiology is of this. Maybe we're still investigating. Great, if this has been present for 6 months or more, we can be putting them on a plan, and we can be utilizing the plan to help plan and track the care and management of this chronic pain. Beautiful. Put them on a plan. They don't have to be accessing any multidisciplinary team at this point. They don't have to be seeing any specialists. That's the difference between the old framework and the current framework. We don't have to have those minimum 2 providers. All we need to do is be satisfied that they meet that eligibility criteria. When can we review these plans? Well, as I said before, we can do a formal review every 3 months. We can do a whole new plan if there is something that has significantly changed previous to the old plan, or a new condition has been diagnosed or has presented. So in that case, you would just put your explanatory note in with when you submit your billing to Medicare, so that hopefully they can say, okay, they will pay for that. Can someone assist with reviewing or preparing the plan? Yes, this is where it talks about the practice nurse or Aboriginal health workers being able to assist the doctor to do these plans. That hasn't changed. So this is a big one that has been starting to cause some conversation. A practice nurse assisting with the reviewing of a patient's plan. Can we claim the 10997 as part of that review? No. Generally speaking, it can't, just for assisting the doctor with the preparation of a plan or the review of a plan. It's all inclusive in that medical service. Okay, so if you're just, perhaps doing some baseline observations while you're doing some information gathering and putting the plan together, that is information gathering. Doing obs is information gathering. It's not necessarily considered that you're doing something separate to the plan. If, for example, you do another service on the day that can be attributed to the ongoing management of this person's chronic condition, and one of the examples I like to use is perhaps like a Prolia injection. So someone has got osteoporosis or osteopenia, they've been prescribed the Prolia. They think, well, whilst I'm here today, I might as well get the script for it because I'm due next week. Doctor says, okay, here's the script. They run off next door to the pharmacy and then bring the script back, and then you've been authorized to administer that injection today. So you've done the planning and you've also or the review, and you've closed that entry down. Now that the patient has come back, you can open up a new entry in that patient's note, just specifically for administering the Prolia medication, and do your normal things that you would do for that and document. And you can write on the bottom of your entry for this particular treatment that 10997 is being claimed for this service as part of the ongoing management of the patient's osteoporosis. You should have that written in the care plan that a practice nurse is able to administer the 6 monthly injections as prescribed by their GP. If that's the case, then you can link it into something that is put into their plan, and you can go ahead and submit the 10997 that day. You've documented why, you've shown the relevance, and you're identifying that this is the thing that you have done today that you are claiming that nurse item number 4. Okay, so I hope that's really clear. If you've got it documented in the plan that this is an action that the patient that is in the patient's plan that the nurse can perform, and it is separate to just doing the review or just doing the care plan preparation part, then by all means go ahead and submit that to Medicare. It shouldn't be something that is just routinely done just for the sake of, I brought the patient in and I did their obs. I don't think that that's what they're intending it for, unless it's very specifically laid out in the notes, in their plan. And then when you document it in your notes that you are doing that particular task specifically for the ongoing management of their chronic condition. Okay, I hope that makes sense, because I don't know how much clearer I can make it. Okay, do we need to have a minimum time spent to do the plan? No, we don't. As long as you are meeting all of those requirements in the descriptor, then you're good to go. Does the plan expire? No, it doesn't. However, if the patient wants to continue accessing those MBS supported allied health visits, then a plan or a review must have been done in the last 18 months. Okay, very clear. The number of allied health services has not changed. Okay, so 5 individual allied health services, or 10 if they are First Nations people and they've had a health check done. And of course, the group allied health services are also still available. Okay, so none of that has changed compared to the old framework. Alrighty. The referrals have changed, and here is where they start to talk about the referrals to start with, and then they do elaborate that a little bit more in the explanatory note. As I said before, as long as that plan has been prepared or reviewed in the previous 18 months, then those allied health visits don't expire. okay, unless the doctor has specifically put something in there. They cannot be an indefinite service though, okay? So that's how they differ a little bit from, say, a specialist appointment, a specialist referral where you can do an indefinite referral. You can't do that with this, okay? Because this is meant to be reviewed, alrighty? Okay, so we've got 5 allied health services per calendar year that they can be claimed for, okay? So if the patient wants to have more than the 5, then of course they can continue to access those services beyond those 5 things. They're just not going to be the Medicare subsidised ones, okay, or through the care plan subsidisation. So that's just where that kind of talks. And as long as you're letting the patient know that, then by all means, you can, and just let them know that they are going to have to privately fund that either through their private health insurance or just out of their own pocket. Here's a really interesting question. Do any of the unused visits carry over into the next year? So say you've given somebody 5, they've only used 3. Those remaining 2 will not roll over into the next calendar year, so that adds on to the next 5. Okay, so they come in January and they say, can I have 5 more visits for the year? I only used 3 last year. I've got 2 left over. Does that mean I've got 7? No, it doesn't. Okay. Do we need to put how many visits they would like to attend? No, we don't. We don't have to specify the number of services in that referral. And their rationale for that, and they do explain that a little bit further along, is that because they want to give that flexibility to the patient and also to the treating practitioner. So you've given them 3 sessions to attend the physiotherapist, and they've done that 3, but they could benefit with more. And the physiotherapist says, well, I would like you to keep coming, as long as the patient is aware that it's not going to be funded through the MBS supported ones if they've used up all 5 collectively throughout the year. They can absolutely continue to have the treatment. I think maybe there was some confusion, and maybe that's why they felt the need to have this clarified. I'm not really sure about that. Yeah, it's not, you don't have to. Should you? I am in agreement with being able to document where it goes, but we'll talk about that a little bit more in a second. All right, they're just talking a bit more about Medicare, telehealth, and they're just talking about, that's the numbers there, claiming restrictions. So generally you can't claim on the same day as a general attendance. Again, if it's absolutely necessary and the GP can document that this is a completely separate thing that's happened, or maybe they've come in the morning and they've had their care plan done, gone home, later on in the afternoon they've had a fall, got a big injury to their arm, big skin tear, and then they've come back to have that wound care attended. In that instance, yes, you can timestamp your different appointments. You can send that information to Medicare through when you're submitting your billings, and just identify that they were 2 separate occasions and for 2 separate treatments. And in that case, yes. Would they like to see that happening all the time? No, but as long as you can justify it and prove it, then you should have the right to put that through. Okay, so in this particular additional note, they are just talking about other things that are available for people with chronic conditions. So your regular appointments, your health assessment items, the nurse support item numbers, medication reviews and case conferencing, and of course mental health care planning and stuff like that. So that's just all of those things. Multidisciplinary care. So they're just talking about all those allied health services in that, and I'm not going to go through those things. That's the different types of allied health service. Nothing has been added or subtracted compared to the previous framework. So I'm just going to go through all that. How do I check an allied health professional is eligible? Generally, if they're a Medicare registered, then they're eligible to be sent the referral. Do they have to accept it? No, they don't have to accept them. That's their choice. So I always say to people, if you ring up the provider and they aren't accepting them, then that's okay. Just call back and let me know, and I can redirect it to somewhere else. Transition arrangement. So this is important because it does outline what the situation is with moving from the old framework to the new framework. So they've given us 2 years to transition people from the previous care plan, team care arrangement framework over onto the new framework. Alrighty. So basically what that means is anyone who was on the previous plans now, next time you see them, whether they were due for a whole new plan or a review, you're going to transition them onto the new framework by doing a new chronic condition management plan and submitting the item number 965 if you're a general practitioner. Alrighty, because you're not going to be able to submit a review item number because you haven't done an actual chronic condition management plan yet. So that's pretty much what you have to do. I've heard people trying to put through the new review item number because they're technically due for a review and that 967 is bouncing back. That's because they haven't actually commenced on a new plan under the new framework. Okay, so they will need have a GP chronic condition management plan in place by the end of June 2027 before otherwise then they'll note that none of that will previously be relevant, okay, and they won't be able to access anything like the 5 allied health visits and all of that kind of stuff. Anything that was put in place before in terms of the referrals to allied health, they will be still able to attend those appointments and claim for those appointments the same way that they would be doing anyway. So there's no need to bring them in and put them into a new referral. The only thing you'll need to do once they come in to see you for their new plan or their new review is to transition them onto this new 965. Okay. So what happens if my patient doesn't have a care plan in place? So that's what they say. That's what I was saying before. Then they won't be able to access the services like the 10997, etc. Allied Health can continue to provide the services under the previous arrangement. That hasn't changed. They can keep doing that. And all the referrals, as I said just now, are all still valid until all those services have been used up. Okay. Then when they need to come in for a new set of 5, you transition them onto the new format with the new referral letter, okay, and a new chronic condition management plan. Okay, so yes, that's what it says. They'll need the new referral letter. All referrals issued from the 1st of July will need to meet the new requirements regardless of what plan. Okay, so that means that's the letter that you need to do, the referral letter. So same as what we used to do, what we currently do for specialist referrals. So here they talk a little bit more about these referrals, what we need to include, and this is usually input into the autofill if you're using a referral template, which I think most practices do. The name of the referring GP and the practice details and all of that sort of stuff should be there. So this should be in writing and dated. And we should also be explaining the reasons for referring the patient, including any information about the patient's condition that the referring practitioner considers necessary to give this allied health provider. So if the patient gives you permission, then you can submit the whole plan, but that may not be relevant to that particular allied health professional. In that case, you can do a summary of their most important conditions and also what you're sending them there for. So generally, say we've been sending someone to the cardiologist, generally when we're doing that referral letter, the GP will write in there why they're sending this person, that they've been having hypertension, they've got some changes on their ECG, they're starting to complain of some chest pain and headaches or something like that, referring them for this purpose to be investigated by the cardiologist. All right, so you've given an overview of why we're sending this patient rather than going, hey, yeah, thanks for seeing this patient for me for your opinion and management of what. Okay, so my suggestion is that we still continue to document what we're sending the patient for and how many of the MBS supported allied health visits the patient would like to access under the knowledge that the patient can continue treatment beyond those scheduled sessions, and they are aware that this is a privately funded arrangement based on whatever that allied health provider's fee structure is. So I adapted we use best practice where I work, and we just adapted that allied health referral to just basically put in a sentence or two to say that we're sending this patient to you for 5 services under the MBS chronic condition management plan, and they are aware they can continue this treatment in accordance with your own fee structure. So just something simple like that. I can't remember the exact words, but it was very close to that. All right, so does this, so here it says about the not having to specify. So this recognises that some patients accessing may wish to use a higher number of services that are supported by the MBS. And it's ultimately up to the patient and the allied health provider to determine what's ultimately the best thing to do for them. But as I said, I think it just makes it easier. And even down here, they ask what happens if it gets lost or goes astray. And again, this is just so much easier if you're just keeping track of it and you've got it on record. They're also explaining that you don't actually have to specify a particular allied health provider, as in I'm sending them to XYZ physiotherapy. You can just send them to that particular location. You don't have to say, I want them to see Joe Bones at XYZ physiotherapy. Okay. Any physiotherapist at that practice can provide those services. You've sent it to that practice. Okay. So that's what that means about do you have to add in the allied health professional's name? Okay. You don't add the name, but you can add the centre that you're sending them to. Okay. The practice, the clinic, whatever. That just explains about no, they don't have to accept that referral. Can another practitioner see them at that same practice? Yes, you can, as long as it's in that same modality. So it has to be a physiotherapist to claim the physiotherapy sessions, not an occupational therapist to claim the physiotherapy sessions because they happen to be working at the same practice. No. And here it just explains that there's no indefinite referral. So that is written there in black and white that it can't be an indefinite referral. They can last for 18 months from the date of the first service provided under this referral. So that means if you have given someone a referral on the 1st of July, that person does not attend until the 1st of August. That referral will commence from the 18 months will start from the day in August that they attended, the 1st of August. All right, so that's when the 18 months will kick in. It's not from the time you wrote it and sent it. So that's a really important distinction to make, okay? And really important why we should be keeping track of who we're sending this to, because I think just freely just sending that out there and handing them a piece of paper and saying, take it where you wish, I don't think that actually really serves us very well in the long run because A, we don't know where they're going and we don't get the information back. So we're getting reports back from people that or we might be trying to chase a report from someone that we referred them to, but if they didn't end up going there, they went somewhere else, well, then it's actually just making more work for ourselves. Because even if we do say to the patient that it's your responsibility to bring this back to us, we're still relying on that. And whilst it doesn't really change anything in terms of our billing, because we're no longer reliant on having that communication between the minimum of two providers, it does impact the plan. Okay, so we can't accurately assess the relevance of the plan, the relevance of the treatment, the relevance of the referrals, and how any improvements that have been happening if we don't have that documentation, that information coming back from those allied health providers. So whilst Medicare is being a little bit airy-fairy and they're saying, oh, we don't need you to track this, I think it's just good practice to do it. Not saying we're taking away any agency from the patient. By all means, advocate for them to be as much as involved in their plan and involved in their allied healthcare as physically possible. We know that some patients just aren't good at that and we can't rely on it. So in order for us to make sure that we're providing the optimum treatment and we can document that we're doing the right things in terms of keeping up to date with that plan, then I think we do need to still kind of keep a little bit of a watch on where things are going. So I'm personally going to be making sure that I'm tracking where they're going. And I say to my patients, if you decide to go to a different provider, not a problem. That is absolutely your choice. Just let me know. Here's my email number. Here's my email for the nurse, the practice nurse at the medical centre. Shoot me an email and just say you've decided to take your referrals somewhere else, and I can at least then adjust that in your plan so that we know where you're going now to get your treatment as part of your chronic condition management plan. And they're usually pretty good at that, and they'll just get back to me and say, yep, I've decided to go somewhere else because I couldn't get in quick enough to the place that you referred me to originally. Great. Okay. I think that has brought us to the end. So I think the main pertinent points I just really wanted to make sure we clarify here is that these are structured plans, okay? And we need to make sure that we're doing that in our plan, whether we're using the templated formats that come in our software. As I said, I use Best Practice, and with the update on the 1st of July, they did come with a new template, which is located up in your word processing documents. You can still also use the enhanced primary care plan, which is down on the left-hand side of the patient's file. You can still use that. When you go in and just says, create new plan, it doesn't actually have the new terminology on it yet, but when you print it, it does. Go figure. Whether they fix that little issue, I don't know. But it does actually come out as a chronic condition management plan. It doesn't say CCMP anymore. And of course, you don't have to do the 10 care arrangement section of it anymore, so you can still just use that side section if you wish. That's what I like to use. And so, yes, so continuing to do this structured approach to care. And so we're doing that in our plans, but we're also doing that in our reviews, okay? And the thing to remember here is that this is future focused. Doesn't have to have the whole backstory. You can be doing that down the track at your reviews if you wish. You can be looking at, okay, well, where are they up with some of their preventative healthcare stuff? But I know there's a lot of conversation around how times have been, the time to do these plans has been cut at certain practices. The time for nurses allocation to support the GP in preparing of the plans has been cut. So just keep that in mind, that this is a living document, okay? It's not just a report where you're just going to list every little thing that's been happening. You're just going to look at the plan moving forward, and then you sort of structure those reviews into the future plan and get them back, and you can be building upon this as you continue to review, okay? So as long as we're doing all of these things and we're accessing those supported services and we're providing those nurse supports that are consistent with the management plan, we're documenting all of that appropriately, then I think we're good, okay? I think you can pretty much just keep doing what we've been doing. I know it certainly hasn't changed very much where I'm working. There's a few little tweaks that we had to make, so that we were happy with how we were going to do these things. But apart from that, it hasn't really changed how we're doing them. The other thing that we are doing is trying to look at, having more people on a management plan. Perhaps in the past they may not have qualified because they weren't seeing specialists, and we were struggling to get those minimum of 2 multidisciplinary team members. So those people now can still go on a plan, and so we're looking at doing that. And we are also focusing a bit more on how we can incorporate health assessments a little bit more into our practice. So yes, also structuring those reviews a little bit more often. We're preparing our patients that they will be coming in for more frequent reviews, and they'll be bulk billed, and that seems to be going okay. But I think that means that we can continue to work on this plan a little bit more often, and still make sure that we're doing all of those things that we probably would have done just in one big appointment once a year. Yeah. Okay, so I hope that's helped to clarify things a little bit more for you. If you have any questions, please pop them in the comment section. If you like the content that I've been putting out, please subscribe so that you can keep up to date when new videos come out. I'm trying to keep things very relevant to practice nursing, and up-to-date information when new changes occur in our world. So always open to feedback as well. So if you've got any suggestions for me, please pop them down in the comment section. I do love feedback. And of course, if you've got any ideas on some topics that would like to be addressed for yourself, then please pop them down in the comment section as well. Until next time, thank you so much for tuning in once again, and I will catch you again another time. Thanks.